Hello and good evening, conference. Welcome to the workforce session of our Summer Conference 2021, where my colleague Louise and I will share the workforce strategy and its implementation and what you as NPA members can do in support of this. We invite you to join us in the debate through the question and answer tab on your screens. And before we start, I'd just like to introduce Simon Wills, who will talk us through some of the housekeeping rules and so forth. Over to you, Simon.
Thank you, Helga. Yeah, brilliant. So just very quickly, Helga just started to explain there. So we've got the chat is turned off tonight. So we encourage you to use the Q&A if you want to send in any questions. Please do so. We'll have time later on for Louise and Helga to answer those questions. So please do send them in throughout. If you have any technical problems throughout, you can't hear, can't see, do just send us a message on there as well, and we should hopefully be able to help you. And the hand raising function is also turned off as well. So as I say, we can encourage you to send anything through the question and answer box, which you should find at the bottom of your screens. But that's everything. So I'll go back to you.
Thank you very much, Simon. So before we launch into the session itself, I think it'd be good just to work through the learning outcomes that we hope to achieve by this evening session. And what we're going to go through is to understand the new GPHC initial education standards of pharmacists and what this means for community pharmacy and us as NPA members, increase the awareness of how community pharmacy will evolve over the years ahead and the skills that are needed to be fit for the future, and also apply these learnings to enable changes within our own community pharmacies to embrace the future ahead. As I already mentioned, please enter any questions you might have in the Q&A tab at the bottom, and Louise and I will endeavour to respond to these questions at the end of our session. So, initial education and training standards. So we have seen, particularly over the pandemic, that the patient journey is constantly evolving with a drive towards a more patient-centered approach, which means that we are seeing more treatments and clinical therapies available closer to a patient's house. That is, within the primary care system, as opposed to a more traditional approach in the hospital-based therapies. So launched in January 2021, the GPHC initial education standards for pharmacists have been revised to reflect this increasing role. Now, embedded within these standards are also, for the first time, independent prescriber standards, which have been introduced from year one of the student journey, so that upon qualification, the pharmacist, the qualified pharmacist, day one qualified pharmacist, will also be an independent pharmacist prescriber. So it's hoped that this will start from September of this year, so that we will see the first newly qualified pharmacists and independent prescribers at the same time from the year 2026. So we're hoping that we'll be able to apply this. So key changes within the standards are as listed on the slide. We're going to incorporate the skills, knowledge, and attributes for prescribing. So pharmacists will be able to independently prescribe from the point of registration. The whole new set learning of outcomes that will assess the full 5 years of education and training, as opposed to the current position where you have an exam at the end of 4 years and then you have a pre-reg year. So this will all change. And there will be a greater emphasis on the application of science. Ultimately, we are the scientists on the high street in clinical practice, to include a greater focus on key skills such as professional judgment, management of risk, diagnostic, and consultation skills. The 5th year of education and training, commonly referred to as the pre-reg year, will also have a strengthened supervision and support with more collaboration between the higher education institutions, the statutory education bodies, and the employers. For example, in England, this will mean the universities based in England, Health Education England, which is the statutory education body, and the employers, of which we are some of them, the NPA. We will now call this the foundation year. In addition, the pharmacist pre-reg will now be known as the foundation pharmacists, and the tutor will become known as the designated supervisor. The foundation pharmacist, as mentioned before, will now work towards learning outcomes as opposed to performance standards. You will be aware of the 72 performance standards that a pre-reg needed to meet, but now we have learning outcomes. And eventually, the pharmacist pre-reg year, normally in one setting or at most in two settings, hospital and community pharmacy, will evolve into multisectorial placements. Those pharmacists who previously were referred to as foundation pharmacists, i.e. those pharmacists in their first 1,000 days post-qualification, will now be known as early years pharmacists. At the early stages, and again, Louise and I will talk about in detail further later on in the presentation, at the moment, these are changes in the nomenclature. Over the few next years, as the implementation phase ensues, there will be some changes into the roles and the responsibilities of the foundation pharmacist, of the designated supervisor. But for this year, things have remained much the same as they were, but we're starting to see a slight introduction. So in contrast to previous workforce policies, where there was a UK-wide approach to the implementation, this time the regulators confirmed that each country will implement and apply these standards to their own pharmacy strategy. Next slide, please. The NPA has been working and will continue to work very closely with key stakeholders on the creation of these standards, and is now involved and working with the UK pharmacy education institutions on their implementation. So in Scotland, we are working very closely with NES. In Wales, we're working very closely with HUE. In Northern Ireland, we're working very closely with NICPLD. And in England, we're working very closely with Health Education England. In fact, Health Education England has invited us to endorse the Trainee Pharmacist Foundation Year Assessment Strategy, which is something we've been supporting them with. And we have endorsed it and confirmed that endorsement last week. Now, one thing we also need to bear in mind is that the current entry requirements into the foundation, old money, pre-reg, will vary across the 4 nations. In Scotland, this is managed through NES, as it has been, whilst the mixed placement in Wales, which have been introduced, shall we say, 2 years ago, are managed through HUE. In England, the hospital foundation year and the mixed placement, so those of us who have got a 6-year placement with either a GP surgery or a hospital, are mandated to use the ORIAL process, but the whole ORIAL situation is still optional for community pharmacy in England. Question is, how long will that continue? But it's good to be prepared. In Northern Ireland, the process remains unchanged, with the community pharmacy employing their own foundation pharmacists directly at present. But one thing we need to be clear about is that eventually, in all 4 countries, the quality of the placement we offer to our students may become a key factor in the pharmacy becoming eligible to become a placement provider. More of that later. Next slide, please. Whilst this session is talking about workforce, it's important not to see workforce policy as a policy in its own isolation in silo, but it's actually one of the key enablers to a successful pharmacy sector. At the same time, we need to be aware that there are another 2 policies, the supervision of a pharmacy and the hub and spoke dispensing, that may also impact on the future workforce skills required for the pharmacy of the future. We know that these 2 policies are seeking to automate and delegate the supply and dispensing process for the pharmacist to be able to pursue a more clinical role, irrespective of workplace setting. The clue is in the Independent Pharmacist Prescribing qualification. Also, we need to be mindful that over the past year, we also began to see the impact of Brexit on our workforce. And some areas, I found it rather difficult to recruit the pharmacists and members of the pharmacy team, such as pharmacy technicians. But we at the NPA will continue to advocate and influence key policy decisions, such as we've been successful in the inclusion of the pharmacist role on the Home Office shortage occupation list in April of this year. I will now hand over to my learned colleague, Louise Baglall, Head of Learning and Development, who will share further how the NPA can continue to support you through this workforce transition. Over to you, Louise.
Thank you very much, Helga. So I'm going to talk to you about embracing the change for foundation pharmacists and what that means. So I'm going to talk to you about the current foundation pharmacies, embellishing on what Helga has talked about over the last 15 minutes, and then talk to you about existing IPs and the current workforce who are non-IPs. So I'm going to talk to you a little bit about that. On the screen in front of you, you will see a timeline, and timeline dates from this year all the way through to 2026. Helga has very much alluded that all undergraduates will come out will be IPs in 2026. And it's really important to take this on board about what that means in the future, and thinking about the clinical future, and where we are with the existing foundation pharmacists and PreReg programme. So in 2021-22, the cohorts will be similar to previous years. So there has been a transition to mixed placements in some areas where pharmacists or PreReg pharmacists are working alongside GPs and community pharmacy, and that's becoming more apparent, and I've seen a lot more activity this year. But as the years go by, through 2022 to 2025, there will be an awful lot more split placements. So undergraduates will have placements in different sectors and settings: community pharmacy, hospital, and within a GP surgery or sort of PCN setting. And these will be changes that will occur over the next few years. HEIs, I believe, are currently looking at their programs as they are now to look at how they can incorporate the IET that Helga has been talking about, the new initial education and training standards over this time. The NPA are very much in support of these placements and want to give you confidence that we want to support community pharmacy as we always do. We want to make sure that there is a level playing field for independent community pharmacy, but it will look a little bit different to how it does now with the placements, the learning outcomes, and also with funding. So these things need to be addressed. But we want to provide the skills and the training for these placements for you and your teams, so that clinical pharmacy is supported in community pharmacy within this year, and we can build on the vast experience that we've got as we've trained thousands of PreReg students over the year. So, and the NPA will work with HEIs, and we are doing so. Helga is very much sort of embedded in that space, and I am from providing accredited courses to HEIs, and some people do, some universities actually do want our accredited programs, but we want to ensure that these are the skills that we've got and the support we can provide through either a full foundation programme or a partial foundation programme, that we're embracing these changes. I'm now going on to talk about the current workforce, and this is the non-IP workforce. So we have on the register for the GPHC, there's 11,300 IPs currently that have the IP qualification, but obviously the majority of us, including myself, haven't got an IP qualification. So this slide depicts a few things to considerations and some known issues within the market, because this is very much sort of a work in progress. But the Scotland, Northern Ireland and Wales are ahead of the game compared to England, and we are more at an embryonic level of IP than the other nations. So the first question is how? So how are we going to become an independent prescriber? Well, the GPHC have some standards which were set out in 2019, and these are the initial education training for independent prescribers. You have to be a registered pharmacist, you have to have a good standing with the GPHC, and you have to have at least 2 years experience in a patient-orientated post-registration world, you have to have identified an area of clinical practice. So you have to specify which area of clinical practice you want to work within, and you have to have a designated prescribing practitioner. They call them DMPs or DPPs. And so those are the entry requirements that the GPHC adhere to, and they're the basic really entry requirements, and each HEI will look at different entry requirements. So it's really important that if you're actually looking for a course, that you actually look at the HEIs. There's 47 of them with slightly different entry criteria. But to become an independent prescriber, you have to go on a GPHC accredited course. So the programme has to be accredited by the GPHC. And for those of you that don't know, it's a 6-month course. Some courses are distance learning and some actually offer some face-to-face elements. But the most important thing really is considering how you will do your 12 days of learning with in practice with your mentor, your medical practitioner, or DPP or DMP. So that's really an important consideration to think about how you're going to become an IP. When? So when will be an appropriate time is really dependent on yourselves and your, there's some people that would have to sort of bridge the gap. Some people will not have had any training for accredited training, let's put it like that, for 20 years. You'll do your CPD as normal, but you may not have actually done a course of 6 months. So it might be quite a lot harder in those sort of cases. But there are ways in which you can actually consider how to do this, and you might actually have to do a bridging course to be able to do that if that's what you want to do. But you have to understand what's expected of you before you sort of enter into this world, so that you can actually give it your all to become qualified in this area. And but there will be help. There'll be lots of mentoring, so you'll actually be helped with your study to actually progress through the course. What the cost will be? Well, in England, it hasn't been decided from a community pharmacy point of view at the moment, and Helga is in conversations and she might be able to give some more information about that. But it's at the moment we've actually got to understand how we will be funded, or it might have to be partially self-funded. That information isn't available at the moment. But really, you've got to think about what's in it for me. And we're thinking about what services that you could do from an IP perspective if you get the qualification. So there's Helga's talked about commissioning services across in, say, the Northern Ireland, Scotland, Wales. The model looks very different, and you can you've got more opportunity to participate wider with your IP qualification, and that looks very different, as I say, within the different countries. But there's evidence out there that actually shows that IPs can have a big role to play within community pharmacy, and there are lots of different services such as blood pressure, hypertension, and titrating doses of medication, and looking at minor ailments in a greater detail with prescribing things like antibiotics. So I've talked a little bit about sort of bridging the gap, but there are a lot of known issues. So that we know that the DMPs and DPPs that we've heard from members, and obviously with key stakeholders, that they can be quite difficult to find. And this is a known consideration, it's a known issue, and we're addressing how this could work a little bit more effectively, and whether DMPs potentially could have more than one student. Historically, I put this on the slide, but this was a little bit of more of a known issue a little while ago, and I think, having looked at some of the courses recently, that HEIs are changing a little bit, that they are including pharmacy more, whereas, and I've noted a lot of community pharmacy courses available. Historically, when a lot of the board have done the courses, etc., they've been very nurse focused, and this changes very much that community pharmacy are really embracing this, and you're not in a cohort with all nurses. That shift is changing. So but it has been seen that it's been very much a nurse-led sort of course, but those times are changing. How can we offer this in community pharmacy? What are the practicalities and issues about offering a course and actually spending those 12 days of learning with your DMP, DPP? Again, a known issue, but it's being looked at. The workforce issues, again, with workforce, there's a little bit of migration into PCNs and the ICS. But what are we going to do with an IP within community pharmacy? And that's very much what Helga is lobbying about, to make sure that we are using our skills effectively in the community pharmacy. And the last thing I want to talk about was supporting and returning to learning. It could be daunting. It could be daunting to a lot of members how they actually embrace the new learnings, but we are at the NPA looking at how we can support you to become an IP if that's your chosen profession. So this is a slide that talks about looking at the current workforce. So as I've said, there's 11,300 IPs on the GPHC register, which will be from all across from in primary and secondary care. But some IPs, as we know, and we've been speaking to members, don't feel comfortable perhaps in using the skills and feel that they want to increase their clinical capabilities to be able to do that, because we know that there's a more clinical future and we really want to build on that. So there are known issues with taking the jump. We have lots of calls. Jasmine's team in pharmacy services have a lot of calls in relation to IPs, and it's a known issue that some people haven't used the qualification. So how do you use the qualification? Well, you can use a qualification in many ways. One of those could be actually through a clinic environment and offering clinics to your populations in certain for certain conditions. This could be the first step on the ladder, which may be through a private route for some people, but can be through a commissioned or sort of an enhanced route, depending on your locality. And this is really getting you started on the ladder in some cases for your IP journey. And it's really important to sort of embrace this change and actually move forward. That people maybe not be that confident about actually making this jump and making this change. So at the NPA, we're looking at ways which we can improve people's confidence and encourage and support IPs. And we know that there are a lot of trailblazers members that are IPs, and we're talking with some of those to actually address how they've worked and the good news stories and actually workings and how things have worked well, to be able to share those messaging. How to set up a clinic is something that is very much asked. So obviously there's the insurance element that you've got to think about. You've got to think about the space that you've got, say the consultation room, the waiting area, the booking systems, what IT systems you're going to use to set up appointments, what records you should keep, and all the clinical governance that goes with that. And how can you market a service? What's the footfall going to be like? What are your comms going to be like with GPs? And it's just looking at all those different elements to see how you can be supported in this area. So it's quite a complex area. IPs have been around since 2006, I believe. So there's a lot of IPs out there, some of which are obviously practicing well, and we want to be able to bring you those good news stories and actually share ways of working across independent community pharmacy. Just for your records, I've put an insurance there. Insurance, there's an indemnity statement just at the bottom, but I think it's really worth pointing out that it's not included in a normal insurance policy from the NPA, and you would need to notify the insurance team at the NPA to be able to provide adequate insurance for providing those services. So there are elements that we need to consider as well, and having spoken to quite a few IPs, whether you use PGDs or you don't use PGDs, and from talking to IPs, it really depends on the services and at the service providers and how capable and confident the individual is. So some IPs will still use PGDs. I think this tends to be more so in the travel space, when they want to offer travel clinics and support travel clinics, and IPs are feeling more confident with using a PGD where there's a lot of complexity with different locations of travel. But in other areas, they feel that if they have the appropriate training and they can sign themselves off as being competent in that area, they will not use a PGD in those circumstances. Being an IP, it's a bit like having the building blocks, so it very much being clinically competent in one area and specialising in that, and then building on experience with training to provide other services in clinical areas. So it's actually increasing that breadth of your clinical provision to provide more and more services in your community pharmacy. And as you increase the breadth of the clinic provision, you will also improve your confidence. There are systems out there, and the NPA are looking at a lot of different systems at the moment that you can use for IPs, as in to record all your consultations. There's different templates and clinical templates that you can use on these different system platforms. And we are looking at quite a number of these so that we can recommend the systems to you, or actually just show the differences, as in, say, a which guide, to show which systems we think what are the benefits of the systems. So there's a lot of support out there, and we are driving these changes. So in summary, the NPA, we continue to shape the future of clinical pharmacy and community pharmacy, and we do this very much with yourselves. We know that there's going to be a more clinical focus on the horizon, and we want to embrace this change to support you on this journey. There has to be a further integration of healthcare systems, and because we won't be able to do our jobs properly if we haven't got integrated systems available to us to provide best patient care. NPA members, you are innovative, you are agile, and you are pioneers. All our members are at different stages in the IP journey, but there is a lot of innovation out there, and there are a lot of NPA members who are really, really trailblazing in this space. So it's great to understand, what's happening in this space and how we can support further. Your role models in pharmacy, you are part of the future. You've got to, we together as the NPA and our members need to actually embrace these changes and change pharmacy over the next 5 years and the future for us. We continue to support you as we navigate through these changes with Helga in regards to advocacy, myself in regards to development of services and resources with my L&D team. We want you to create different services, so develop different services to be able to embrace and utilise all the skills that you've learnt as an IP pharmacist. And obviously at the heart of us all are our patients, and actually addressing getting better patient outcomes for our patients is essential in this world to make sure that we're all benefiting in our environments. So this slide depicts what information is available. So for anything related to workforce, we've got Helga's email address there, which if you want to ask Helga any questions, obviously we've got a question and answer session in a second. For anything to do with training and support, it's myself and the team, and the email is available there. Insurance, indemnity queries, please contact our insurance team. And there's some information on IPs which you may or may not have seen. We've created an IP website, an independent prescribing website. It's got an awful lot of information available on independent prescribing, whichever stage of the journey you're at and from whichever country you're living in. So there's a lot of information that Jasmine and her team have kindly put together, which is available on the NPA website. And I'm going to pass over to Simon. Simon's going to answer, well, not, I don't think Simon will be answering, Helga and I will be answering. You can if you want, Simon.
I will try. I won't, I'm sure I won't trust it, but yeah.
So Simon, I'm going to hand over to you, Simon, to field any questions that we've got from tonight's session.
Fantastic. No, thank you both. That's great. And yeah, thank you to our audience members for their comments and questions. So I'll put those to Helga and Louise now. So start from the top. I've been qualified for over 20 years. Is it worth my while undertaking an IP prescriber course? Oh, Helga, you're on mute.
Let's all break into song. You're on mute. The catchphrase for the pandemic.
Indeed.
So yes, thank you, Simon. That's a very, very good question. I guess this is something that I personally believe, and also as the NPA policy, that absolutely, why not? And that's why we're trying to endeavor and work together behind the scenes, Louise and I, and our teams, to ensure that we are going to be able to have availability of the independent prescribing course to all of our current workforce, while the focus is on the newly qualified, if you like. And I guess for me, it is something that's terribly important. How often have we been in the pharmacy, particularly now, with the CPCS service, for example, where we know exactly what is wrong with an individual. We know that they've got a UTI infection. We know that they've got an ear infection. We know what's wrong with them. And wouldn't it be great if we had the tools and the resources, if you like, to be able to complete that treatment solution, instead of what we currently do, send them off to their to out of hours doctors, and then 3 hours later you see them with a prescription precisely for the antibiotic that you thought they needed in the first instance. This works very, very well in some of our devolved nations, such as Scotland and Wales, because they do have an independent pharmacist qualification. In fact, it's in the Welsh and the Scottish strategy that every community pharmacist is also an independent pharmacist. Yes, also in the pharmacy. Sorry, too many words there. So yes, that's really important. So that would be our view, that we will continue to do that. So yes, if you have been qualified, whether you've been qualified for 2 years or 20 years or more, why not? We will support you to do that. And I refer you to the last slide that Louise had put up. We have further information on the dedicated webpage on the NPA, or you can write to myself, you can write to L&D team, and we'll help to give you some solutions to how you can be able to do that. I'm not sure if Louise had any further thoughts on that question.
No, I think you've got to decide obviously where you are in your journey, but I think over the next few years it would be appropriate to do an IP course. So yeah, definitely, because the future is there to take, and it's really good to embrace. The more and more we can actually engage with more clinical services, will be better for, I think, all of us in the long term. Thank you, Helga.
Thank you, Louise. Simon, have we got any more
Fantastic.
questions?
We have indeed, yeah. So here we go, another one. I'm expecting a pharmacist pre-reg student this year. Would I need to be doing anything different from previous years?
In short, no. Basically, what has happened this year, particularly in the first year of implementation, is a change of nomenclature. So your training plan is going to remain the same. Your expectation of the student is going to be the same. If you're in England, you are still the employer, they are the employee. And regarding to the courses that's available, absolutely not. But what you may see, particularly if you're in England, is access to some further resources through the statutory education bodies such as HEE, which it's not mandated, but which you can avail of and make further use. Louise is also, hand over to her in just a moment, but of course there are considerations being taken in regards to the pre-reg program. But as I said, this is an implementation phase, which is slowly, but in the first year, it's us getting used to different nomenclature and what this would look like into the future. Louise?
Not really much more to add, really, Helga. I mean, the foundation program that we're offering this year is we've actually included vaccination training, because we feel that it's very important for these students to actually have the pre-regis to actually have the training and the appropriate training there. Also, in relation to clinical training and clinical consultation, we are recommending that in England that the pharmacists do the CPCS course as well, so that it's really appropriate that they're actually embedded in sort of minor ailments and driving that part of the profession.
Great.
Fantastic. Thank you both. Okay. I'm expecting a pharmacist pre-reg student this year, which is a split placement with the GP. How do I develop a training plan? And would they have 2 tutors/supervisors?
I think I'll answer that question, Helga. Yes, this is a question that we have actually been asked before, and it's really important that the training plan is appropriate, and it's obviously submitted to the GPHC. If it's a split placement, the learning outcomes need to be between the GP and the community pharmacy. And yes, they would have to have a designated supervisor or a tutor, depending on which name changes. Everybody's using all different things. It's becoming so confusing at the moment, but it will become very clear in the years ahead, I'm sure. So yes, they would have to have a designated supervisor at the pharmacy and at the GP practice. And on the training plan, which is submitted to the GPHC, and this would all have to be very much detailed where they were actually providing the training from.
Great, thank you very much. Okay, I got a couple more here. So, will there be enough jobs for these new pharmacists who will now have the independent pharmacist qualification?
So, in 2026, we're expecting every single qualified pharmacist to also have the independent pharmacist qualification, dependent prescribing qualification. Sorry, I'm getting my words confused here. So in essence, that would be approximately 3,000. We always have about 3,000 newly qualified pharmacists. We normally tend to see in the region of about 1,500 to 2,000 who go into community. So that's really what we're expecting. There is a concern that will there be enough jobs? Yes, there will be enough jobs, because we are continuing to advocate for, not for certainly in England, much better services that we can be able to utilize the independent pharmacist qualification. But also we can see this happening and also in the devolved nations. And in some of pharmacies in the devolved nations, they will go on to need, because of the services that are being commissioned to address health inequalities, in some instances they require more than one pharmacist on site to be able to provide this. So yes, I guess an independent pharmacist will not take the role or the job of somebody else, but what it will enable us to do is to complete that treatment, if you like, complete that solution to the customer who's come in with a particular ailment. Yes, I say minor ailments to begin with, because that's what we see on a day-to-day basis. Why wouldn't we not be involved in some further clinical therapies? As I mentioned earlier in the course, we're seeing much more therapies taking place close to the person's home. We may have personalized therapy. We'll have the science of genomics within our community pharmacies. These all require the skills of an independent pharmacist. So yes, I'm sure that there will be enough jobs. Naturally, I do not have a crystal ball, but why not? It's be able to complete the role that we do with the skills and the knowledge that we already have when we've qualified in the first instance. Thank you, Simon.
Excellent. Okay, and we've got one more question here. How many registered IPs are there at the moment, 2021, and how many IPs are we expecting in 2026? I think you did touch on that.
I did touch on that one. So the last workforce survey that was undertaken in 2017, we had in the region of about 500 independent pharmacist prescribers in the independent community pharmacy. Now, some of you might have, if you are in England, might have participated in the HEE workforce survey that just closed, say, 2 weeks ago. So we're expecting more up-to-date figures to come out shortly over the next month or so. So that's where we'll know what we'll have more IPs. And from the questions, and I'm not sure if Louise would argue differently, but from the questions that we get into the NPA, I would argue that there is a fair proportion of independent members, NPA members, who already have the independent pharmacist qualification. How that compares with the other CCA companies and so forth, I cannot tell you until we get the figures. But as alluded to earlier, we are expecting that every newly qualified pharmacist in 2026 will also have the independent pharmacist prescriber qualification. And given that the entry rate is close to about 3,000, slightly less, so we say 2,800 there or thereabouts, we're expecting that number to be more in 20. So whatever we have it'll be a plus 2,800. I'm not sure quite how the figures this individual is asking, is about the new qualified or whether it's a cumulative addition that we'll be able to have.
And I think I definitely alluded to earlier that there's 11,300 IPs actually on the GPHC register currently. That's the GPHC is annotated with those 11,300, but they are obviously across all sectors, community, hospital, industry, etc. So, it'd be great to actually know that number. I mean, which we hope we'll find from the workforce survey.
Indeed. Thank you.
Thank you both. Excellent. Well, I think, yeah, that's covered all the questions that we've had from our audience. So we're a couple of minutes ahead of our scheduled finishing time. So Helga, over to you to wrap things up.
Thank you.
Or
Thank you.
if you want to add anything, sorry, yeah.
Oh, that's absolutely fine. I guess, as I said, this is a continuing conversation. This is a continuing dialogue. What we wanted to do this evening is give you a bit of an update where we are, what we know thus far, what it is we're doing behind the scenes to make sure we get the answers. I mean, this is something that there are quite a number of questions still to be answered. And also to reassure you with my colleague Louise, we have a fantastic learning and development department within the NPA, who produces some fantastic resources. And it's just that we are with you. We are with you on this journey. We will go on this journey together. The independent community pharmacy is an innovative, agile, pioneering sector. We have, risen to many of the challenges that have been held before us, notwithstanding the whole pandemic. And, we will continue to support you to make sure that we have, the right workforce in our own pharmacies and the resources to be able to get the staff trained and supported during these changes. The last slide, as I said, if you have anything to talk about, I know there's some noise about Oriel, about that. We'll continue to lobby Health Education England and NHS England on this process. Please write to me with specific examples, specific thoughts, how I can assist you with that. Questions about the current resources, the IPs, we have a dedicated webpage, and Louise's team, the Learning and Development team, notwithstanding our own Pharmacy Services Department or any other queries that we have. So thank you very much for taking time out to join us and hear us. Please continue to talking to us, and good night and God bless.